there. Welcome to the program tonight or today, wherever you might be around the world. This is a great venue in which the dental professionals, as myself, and maybe if you're a ceramist, perhaps you're an assistant, can all join together and learn and discuss some great education, which is just a terrific format that we can do on this Viva Learning. So welcome to the program, and so very glad you could join us. It's going to be really neat tonight because when I was preparing for this program, I came across this neat little cartoon which I thought summed up what we're all facing for 2013 often, those things called resolutions. I trust that everyone had a very enjoyable holiday season, and quite frankly, I can't think of a better way to kick off the new year than by committing to a few dental resolutions as well. And perhaps 2013 means improving specific systems maybe within your practice or introducing new protocols, maybe even measuring better practice metrics. So whatever you need to work on, that's a good thing, and I think this cartoon certainly portrays that. Maybe one of the systems perhaps you're looking at as well is impressioning. Let me rephrase that, making better or making great impressions. And yes, by making that happen, we can use solid principles that can be applied to everyday dentistry. I am fortunate enough to be able to share a lot of what I do in my bread and butter dentistry type of practice, so I want to be able to help you enjoy more predictability and, quite frankly, make things a little bit less stressful and make impressioning a lot easier. So, quite frankly, tonight we will focus on details, and they'll be able to start implementing a lot of these principles tomorrow within your practice. Here's a neat little fact here. I want to share some interesting statistics throughout the program, but quite frankly, Harvard study did an essay across the board and found out that almost 90% of impressions right now that are sent to labs have 2 or more defects. And this is really pretty startling when you consider that there are over 40 million impressions, and these are traditional impressions. These are not counting the digital impressions, which of course really won't talk about tonight or today. But quite frankly, you're looking at 90% do not capture the margins or that finish line, or perhaps they have a defect, maybe bubbles or voids. That's a whopping 36 million impressions that are really falling short of where they need to be. And foundations, our impressions are the foundation of what we do, so we've got to be really careful about what we're producing within our practice and then what we're sending to our lab and asking them to fabricate that restoration on. We've got to have a really good capture. We have to have a mirrored positive image capture that they can work with. And a lot of times we're really asking our labs a lot to make that impression better or that model better when, in fact, we need to start with the basics and give them a very good impression to begin with. We're quick to blame. We're quick to blame materials. We're quick to blame maybe the timing, maybe the lot number. Perhaps we just didn't had a patient maybe that had too much oral fluid, they were swallowing, maybe they were coughing. But really, in fact, if we can sit there and par down what we're looking at our protocol and how we go through systematically every impression we take, we can make a better product. So there's a lot to consider here, and impression material is really based on some really fine science right now, and across the board we have some great materials that we work with. They've got great handling properties, good tear strength, and quite frankly, their accuracy is right on. So it's really up to us as dentists to make a better product for our labs. But ultimately, when an impression does fail, there's a lot of frustration that's involved in the remakes, and the time and the money involved is really critical. Who pays for that remake? Do you have an agreement with your lab? Or better yet, can you have your lab, and do you have a good relationship with your lab, your ceramist, your technician? Can they call you and say, hey, can you retake this impression? Do you have an honesty factor going on there? And that's really critical. It's very important to be able to have an open line of communication so that you can make an excellent reproduction product for them that they can work with, and then you can deliver it to your patient. You shouldn't have to do a lot of adjustments. If you are, this is a great course for you tonight because you're going to learn a lot of good little tips and tricks to work to make that go away. So here's an impression. I spent some time recently at one of my labs. I work with 2 main labs, and they were kind enough to share this model and then this impression. And I look at this, and this is really sad because your naked eye can see a lot of this model. In addition to the bubbles and the voids that exist here, I want to kind of point out a couple of things here too. There's still some blood on this model as well, and this is really disturbing because it wasn't really disinfected correctly after the impression was taken. So there's some important things that we have to really consider what we're giving to our lab aside even just good capture of that finish margin. Was there a good flash? Was the tissue properly controlled? So we're going to look at all of these kind of ideas and give you tips and tricks to really build up your armamentarium and to make impression materials and processes and procedures much more predictable. Here's another impression here that you can see has some significant problems with it as well. If you look here, you can see some serious voids occurring and bubbles. You've got very poor capture here of this mesial area. You've got very poor capture here of the mesial facing distal surface here on this molar number 30. And I look at this and I wonder about the taper here on the distal surface of this, and we haven't even looked at the lingual surface yet. So we are asking a lot of our technicians to make a good product from a model like this. Where's the occlusion at? I really have a problem when I sit there and look at how this occlusion is on the distal on this number 30. This is tough. So we've got to do a better job. How do we do it? When I look at a picture like this, it really reminds me of how tough it is to navigate in the mouth. We deal with caverns and crevices and moisture and ledges and various dental terrain, quite frankly. The ability to take a good impression is nothing short of amazing when you consider that we're working underwater often in the dark and often around the bend. So how can we make impressions easier and less stressful? This example here does show, I think, an excellent impression. And I want to really go into the anatomy of what an excellent impression requires and how do you get there. You can see here the margins have excellent flash that extend up beyond the impression ledge. And we have great capture there. That ceramist is going to be able to follow that finish margin to a T. This material has dropped down adequately in the sulcus, and we've got a really excellent capture. You can see here from that good impression, we're able to create an excellent model, detailed, highlighted, and lined correctly by the ceramist or the technician to create and fabricate an excellent bridge. This is a very, very good example of what we need to go after with detail. We've got to do better with our positive models for our labs. Accuracy in our world is defined as that 20 micron, 25 micron millimeter line, or not millimeter, but micron line rather, and that thing called the margin. We've got to be able to get into that sulcus and capture just past that area where the finish line is. I'm going to share about a case that I had recently, and you're taking, in this essence, this young gentleman came in, 24 years old, a law student, met the pavement in a kind of an altercation, but initially his trauma comes in, and as you look at these teeth, you wonder, how can I take that to the next step? But you've got to have good impressioning. You've got to have good digital photography as well. And you can see an end result. And he was just in our practice here not too long ago, and we were able to take a picture of him and show 6 months later how good his tissue looks, how good the restorations look, and how well he's taking good care of his mouth. So this is, again, predictability. This is accuracy. And again, this leads all to less stress and better function for all of us. And happier patients, too, by the way. And happier team members. So what is the anatomy of a good impression? What does it require? What do we need to look at? First and foremost is margin capture. And as I was showing earlier, we need to make sure that we have that area that drops down into the sulcus that circumventually goes around that prep, and we have now capture beyond that finish line. So now our ceramist knows exactly where to stop and start to create that emergence profile that needs to come up out of the sulcus and create good gingival health and good oral health long-term for the patient. We've got to have good occlusal capture. You can see here in this picture as well in the lower impression especially how the occlusion is very well captured. And again, you've got two teeth here, molars, that have to have good capture mesial to them. So we've got good stops on this impression. And a couple of tricks I'm going to talk about, whether you choose to do quadrants or triple trays or full arch trays. But you can see in the case above here how, again, we've got two back-to-back impressions, or rather preparations that we're going to take. We're going to use a full arch impression to make sure that captures good and solid. So very important to make sure you have a good and accurate tray estimate in there that fits correctly, and we'll talk about that a little bit too. We've got good interproximal capture as well. No interferences or voids you can see on this. And aesthetic symmetry is also another issue you need to consider. We're choosing the proper impression material because, again, we talked about how there's such good materials out there right now. The difference lies in where and how you use that within your hands and within your practice and within your patient and how you interface with that. Correct timing is another key issue. And finally, no contaminants and proper disinfection. A question that comes up often that I hear is, can I reline my impression? No, you cannot. It will not work. You need to start back to square one and begin from there. Relining will throw off the occlusion. Relining will upset what you've tried to capture in the past and alter. So adjustments are going to be a given. You're going to have more tricks to make that fit down the road. Don't go there. Drop back, take a new impression, start fresh. It's a better option for you. Less frustration. Here's another example just of models, and it's good to look at your models. Make sure that you inspect everything before you do send it off to the lab. A lot of times assistants are in a hurry, or maybe that delivery person's ready to pick it up, or the mail person's ready to pick up your box. Make sure you look at all your impressions. Therefore, you know what you're sending off is going to go to the lab. That's quality. And you can see here, when they're coming back from the lab with your model, go ahead and assess your model. Look at what it looks like. Look what they're looking for. You can see on this right model, the lower arch, you've got nice occlusal stops. They've been adjusting that occlusion, what they've created these restorations and created this bridge from. You can see how they've indexed these dies. They're all removable, but yet they function as a unit. I've got great capture with this. Very, very important. You've got to have a sound, solid bite registration too. You'll notice here this is a bridge, 3-unit bridge, actually 3 abutment bridge with 5 units. Quite frankly, you've got to use a full arch impression. This is not possible and not accurate with just a quadrant tray. It's not going to work. Do it right. Sometimes we want to try to cut corners or save time or space or money. It doesn't work. If you look at the outcome, if you just start with something good and solid initially, you're far better off. So again, make good choices initially. It'll pay off in the long run and the long term as well. And also, I want to mention the use of magnification and illumination. It's very important to use magnification. I hope that most of you are doing that. There's a lot of good companies out there right now that have excellent products. But if you're not using it, I'd certainly encourage you to start using magnification. And different illumination products, again, are super great now. These lights have gotten smaller and stronger. The batteries last longer. They're easier to work and to wear and to function with around the practice and the operatories. So again, I really encourage you to go out there and seek what's out there. Very important. Kind of curtailing what we just saw prior on the slide before this was, again, that model, but now you can see the impression close up. And when I'm looking at this impression, a couple things really stand out to me. One, you can see the nice capture. You can see here how we've taken the wash and the tray material. Tray material is filled up completely, but that wash covers and extends distal, and we get that a good occlusal capture from this rear molar all the way forward up past into that lateral in front of that canine that we're prepping. You can also see here that we've got good balance and good evenness. We've got good tissue capture. Look at the rolled vestibule. This tray fits very well. We don't have to worry about any polymerization shrinkage. It's a good fit. And therefore, you can see the models below hand the lab's been able to work with. There's excellent articulation. They don't have any question. We use a good full arch bite registration, and that creates very good product for them to work with and an excellent product for our patient. So what's my checklist? What do I use? I was going to share with you tonight what I do every day in my practice. Bottom line is I want to have an impression toolkit. I want to have a go-to system that no matter, I work with 2 assistants, either one can come into the office, into that practice, into that operatory, and know immediately where we're at, what we're doing, and how we're doing it. We have developed literally a checklist, step by step by step. They're tuned into what we're doing, and they've helped to create a lot of this protocol as well. So my go-to list on every impression I'm going to take in preparation, number 1, I want to have a good toolkit. I'm going to show you my armamentarium in just a little bit here. and I have proper burr selection. I don't work with 80 burrs. I don't work with 11 burrs. I work with 5 burrs most of the time. I like to be a minimalist in this because I think it's better capture. You're looking at an 80-20 rule on a lot of things we're doing here. Par down what you have. In today's economy, why not? Use the 5 best burrs that can do the preps, and I'll share that with you in just a bit. Good impression material. Again, that's your choice. That's your selection. What works in your hand. Look at colors. Look at contrast. Look at what working times are. And we'll kind of go through a little decision-making process in that in a bit, too. Have good, solid tray selections. Have good bite registration material as well. We'll cover that, and finally we're going to touch on tissue management. How do we control tissue? How do we control oral fluids? How do we know where our margins need to stop or start, etc.? You can see here, this is a setup that I have, and I work with every time I do a crown preparation. I've got my impression material, I've got retraction, availability here, I've got my color matching shades, my Vita Guide, I've got bonding material out, I've got build-up material, and you can see my burr block that I have right here in the center. And again, this is what I use every time. This is totally standard of what I'm doing here. So a great setup here. I work with cassettes. If you're not working with cassettes, I would highly encourage you to use cassettes. They work, and they work very well. I like them because there's consistency, and you have good sterilization features within them, and you can customize what you use best. And it also helps to get your assistants on board because they're going to have a better understanding of what you're using, why you're using it, and they're very prepared that way. A lot of what we do is just because we're not prepared, and things can quickly veer off course if we're not really on task. So I really encourage you to bring your assistants in, partner with them, and get them savvy and get them really jazzed up about when you're doing impressions, because it can be a lot more fun than what we don't want to get too stressful about it, but we can make it a more pleasurable experience and certainly a more pleasurable procedure. Here's some of those burrs I was talking about earlier. You can see here I love working with the two stripers. They're some of my very favorites. I have essentially a gross reduction burr. I think most of us know what those look like. They have the little cross grooves. You've got an interproximal around a football, a flat tapered, and a chamfer, depending on what type of a restoration I'm going to provide and what kind of preparation I'm going to do for the patient. So I work with a little burr block. I don't have, again, a whole lot of things I'm grabbing for. I work with these basically 5 burrs, depending between the taper to the chamfer, that finish line, but these 5 burrs I work with, and that works extremely well within our practice. Again, it helps with inventory, it helps with just assistance, and they know exactly where we're at and what we need for each procedure. So we have a traditional burr selection block that we're going to do for our crown preps. You can see here a picture I included on the bottom right is a burr cleaning block, and I like this too. I don't know how many of you are using this, but it's really good to go ahead and clean your diamonds, especially when you're prepping a crown, because a lot of times contaminant and tooth structure can kind of clog some of that, and you have a better cutting efficiency and a better cutting ability when you clean that burr. So I like to have those out as well within my armamentarium. There's just a nice little caveat there to have available whenever you're doing your preparations. But I like to work with good performing burrs. If you're dragging or things are slow down, throw out that burr, get a new burr. I like to work with burrs that perform and burrs that have a decent longevity. I think, depending on if you're using burrs that are maybe a single or solo use versus 3 or 4 times, whatever you're doing with your infection protocols, make sure you're doing the proper procedures with those as well. So again, that goes into your selection and your preference. Some of the build-up materials that are out there right now are outstanding. I want to feature one tonight that I think is one of the best. I like to work with this material for a lot of reasons, but essentially build-up materials make that structure, and they idealize the preparation to help you create that good prep to make that good impression. They are the framework for your tooth. Good build-up materials are going to have very good radial opacity to them. They're going to have reduced shrinkage, good compressive strength, and the key with, I think, good build-up materials, they're going to not let you create voids. And that's another big issue. A lot of times when we're syringing these materials, we're in nooks and crannies, hard to reach or hard to access areas We're trying to bond these in place, use good adhesion dentistry, and the last thing we need to have is a bubble area near maybe perhaps a finish line or a margin. So I want to work with something that has good flowability. I really like this CompCore AF. This is from Premier. I like it because the radiopacity is excellent. My favorite thing, though, it has extremely good syringing ability, good flowability. It doesn't slump. It stays where it's placed. And the way that this material cuts is so smooth that you really have a good build-up material that's smooth, easy, and delivers all the qualities that you need to have for an ideal build-up. So this is one of my go-to products. I absolutely love this material. It has a fluoride release as well. And it's dual cure, so you can use it in those hard-to-reach areas or those areas you maybe can't light cure or get to. So, again, you got a choice there whether you can light cure or it can self-cure. So this is a great, great product. If you're not using it, get it in your hands, get a sample of it because it really does work. It works very well. There's a couple of shades that they have. You can see here I've got a picture. This is the super white. I like to use a white because a lot of times we've got stained dentin that we're working with, and we need to cover that and mask that, especially with some of the pretty crowns we're using now, the ceramics and the lithium disilicates and the zirconias. We want to have that blocked out, and we want to have a nice capture. And you can see on the very bottom prep here, you can see how nice that looks now. We're able to put a good restoration on that, and that really is very, very aesthetically pleasing. Prep design, an absolute must with adequate reduction. And I think a lot of labs will tell you that the impressions they receive do not have adequate reduction. That's number one. So make sure you don't become that number one offender by creating a poor reduction. Look at your occlusal reduction. That's number one. I think the next thing that's so very important is your marginal capture. And you need to decide when you're going into the preparation, am I going to be doing a shoulder preparation or am I going to be doing a chamfer? Again, that's dependent on what type of product you're going to deliver, and this can apply for either a PFM, it could apply for a gold crown, all gold cast crown, it could apply for a zirconia type crown, a Bruxer crown type, or it could go into, say, even an EMAX. So whatever you're going to deliver, you need to know on the outset, what is my prep design going to look like? What are my margins going to have to look like? When you're assessing that tooth, you need to make sure you have no undercuts. Again, that's where your build-up materials come into play. They helped, again, idealize that prep. And finally, the last thing on your prep design, you need to make sure you have smooth, final preparation that you're going to be able to capture. And I like to use a 30-micron diamond often. I also like to use some polishing discs or cups, and I want to have a surface that's super smooth. Prep design is really important. I know when I was in dental school, I was pretty well taught that you needed to taper of about 6 to 8 degrees. And that's kind of changed a little bit with time with having now some of the restorations we're placing and bonding in with resin cements and such. And I don't want to slack at all and be forgiving on retention principles, but we do have performing cements that work well. But I don't want to advocate anything really over 8 to 10 degrees. I think you need to really stay within that realm. You're going to have a good retentive product that you can deliver with a very, very good resin cements as well. So those are key ingredients. Again, it's on the other end that you're going to deliver this product that you want it to be exceptional. You want it to have a long life in that patient's mouth. Again, some more prep guidelines. Adequate reduction. I can't hammer that enough. You need to have proper reduction. Lingually, you're going to be looking at, in the anterior region, about 1.5 to 2 millimeters. Incisally, you've got to have, excisally, I meant to say that incisally initially. Lingually, you need to have about 1 to 1.5. And occlusally, on most of these preps, again, you need to 1.5 is on a very safe edge. 2 millimeters of occlusal reduction is very adequate and very well and very good. Axially, again, a lot of that's going to depend on the taper of the prep. It's going to also depend on the parallelism of the adjacent teeth, so we need to be careful of that as well. All of these preps now need to have rounded internal line angles. Again, that's also something that helps that impression material flow better around them and create a better capture for what you need to give to lab so they can have a great product for you to deliver your patient. Inlay and onlay preps, another great area here. You've got to make sure, again, very good occlusal isthmus width, 2 millimeters. That's the bare minimum. You want to have a shoulder preparation of that ceramic material or lithium disilicate, whatever you're choosing there, can abut up to, but you need to have an absolute shoulder of 1 millimeter. That's very standard. Especially if you're going to have occlusal or cuspal reduction, absolutely adequate area of shoulder meet. When that material meets that material, it has to have the proper strength and the proper retention form to have that, so it's going to sit in place, be bonded, so that you're going to have a nice, complete product there. One of the techniques I like to use is before even prep a tooth, we'll take occlusal articulating paper and check that occlusion. We see where the stops are. We see where they're hitting, maybe what causes that tooth to fracture, perhaps how their occlusion maybe needs to be adjusted or refined a little bit. That can give you a lot of sense of what your preparation needs to look like at the outset, because now you have a total picture that you're looking at in the future of what that restoration can improve upon for that patient. Again, a neat little tip, go ahead, take articulating paper and check that occlusion before you even start to prepping that tooth or those teeth in that quadrant. Here's some ideas here now for great preps, and I think I follow these on every prep I do. First and foremost, occlusal reduction. I'm going to use that gross reduction burr. I'm going to create grooves that are depth-wise of usually 1.5 millimeters on the occlusal surface. In case sometimes you need to remove the decay or the amalgam, you might need to do that buildup. And then again, check your occlusion right off the outset, because that's the #1 violator and offender that labs will tell you they don't have enough reduction. And I'm not saying to over-prep a tooth. You need to properly prep that tooth. But you've got to develop a systematic approach for this. And this is what these steps kind of show you. The next thing I go and tackle is I'm going to break that interproximal contact. You can see here I'm using a tapered interproximal burr, and I'm going to go ahead and go on the distal of this molar, and then I'm going to come and pass and go on the mesial area. A lot of times I'll even place like a 0-0 chord at this point to help deflect that tissue, so I'm one, exposing a better area and a margin, and secondly, I'm able to make sure I protect that tissue, so I know that I'm not going to engage that and cause any kind of issues or problems with that. I got a nice question here. How much do you usually prep for occlusion to make a solid zirconia crown? I think right now the standards that most labs are telling you are 1 millimeter, but I prefer to go 1.5 millimeters. I think you really need that to absolutely make sure you're doing a proper job for them and have a good way to measure that. A lot of times I'll measure with occlusal bite tabs. We also use wax in some fashions. So great question. Go to your lab and ask them what they're very comfortable with and say, hey, what do you want me to use? And engage that conversation with them, because they're going to help guide you to become a better prepping dentist for these things, these preps. And I tell you, these crowns right now are absolutely stunning. They're beautiful. We can do such great color matching now and deliver really solid products, but have that adequate preparation. Really good question. Next step I do is I'm going to go ahead and I'm going to take a round burr and I'm going to start to follow where I want my finish line to be. And you can see here I'm troughing around this buccal facial area here on this molar, and I know exactly where I want my finish line now to start to go to. And again, I've got burrs identified here on which ones I'm using here, but the round is not, it's a diamond again. It's a 125. Love that burr. It works very well. That starts to give me an idea where I need to visually go and take my finish line to. Sometimes that's altered because you might have existing restoration that you got to work around, perhaps a buildup, maybe recession. Maybe you have, there's different considerations you need to take in all the time. Everything's individual, but again, I like to use that. That really gives me a good visual stopping point, knowing right where I need to go for that finish margin. Next, I like to take a football, and you can see here in this view, I'm using a football to go ahead and now meet my final facial and lingual areas, and I'm going to take this football and I'm going to go ahead and make that football go right into that troughed area, so now I can start to smooth and remove any kind of undercuts. I'm starting to round all of my line angles. I've got another question here talking about, again, ceramics and with anterior bridges, and some very good questions here coming up about what do labs recommend interproximally. And this is a really good question because there is discussion right now about the strength of some of these materials, particularly in bridge preparations. And I know that you need to really work with them and what they recommend, because when it ultimately comes down to it, who's going to be responsible if you have failure of that bridge? So I think you need to talk with them and you need to find out, ideally, number one, how much reduction they need to have in approximately. Number two, what you're connecting, what kind of material you're choosing. Find out what their success lies in. I know my lab has worked with me in the sense that we've moved from material to make sure that we know exactly, we can minimize our failures, and we know exactly how much we need to reduce, because it's really critical. Occlusion issues come into play. You have the strength and you have the resilience of these materials. They've got to perform, but give them the right to perform in the right given indication. So again, talk with your lab and help them guide you. Allow them to do that. They're going to work with you to do that very, very well. I'm going to go on to the next slide here. Finalizing my margins. Again, I'm careful. Sometimes I go ahead and I place that 0-0 chord, and I've got that. In this case, I really didn't. I'm right at about an equal gingival marginal capture of that finish line, and I really didn't need it in this case, and this patient had really good periodontal health. So we went ahead and prepped this to the final stage here where the finish margin is, and then now I'm going to go ahead and take a nice diamond, 30 micron diamond. I'm going to smooth that up, and from there I'm going to go ahead and literally take a polishing disc or cup and create even a smoother preparation. I want to have something that's very nice and smooth, because now I know my impression material flows over it. It's going to reduce any chance of voids, reduce any chance of bubbles. So very, very critical. One of the last things that I do is I go ahead and I will take then a cotton pellet, and I will use 4% chlorhexidine, and I will scrub that prep aggressively. I want to remove all the contaminants, any kind of remaining tooth debris in there, anything that could get in the way of taking a good impression. Remove the interferences. This is a great, great step, because it really helps to make a good product. You can also use hydrogen peroxide. I prefer chlorhexidine because I just think it's something we all have in the practice, and it works well, and it's easy to grab and go to. Finally, then, I think when we look at what determines the best isolation method for that margin, we have to consider, I think, the four most important things. One is how dry is that sulcus? And you can see this example I share with you on this case in particular. The patient had good oral health. We didn't have a lot of oozing. The crevicular fluid was very minimal. He didn't have bleeding. That's the second thing you need to consider. And from that, I'm going to dictate, again, what do I need? Sometimes if I just need to dry that marginal area, I just need maybe just a nice retraction paste, and I can go to that. And you can see that here on the right slide. I've got Traxident in place there, and that was enough to actually dry that crevicular fluid and provide a very, very solid isolated margin once we went ahead and captured that. And you'll see a picture of that here in just a bit. Another isolation method consideration, what is your marginal placement? If you're doing a chamfer, if you're doing a bevel, or not even a bevel, but a shoulder, you've got to know where you're at, because that's going to help determine how you're going to isolate that finish line ultimately for your lab. And finally, look at the tissue type. Tissue types are critical, because you're going to have thin, you're going to have narrow, you're going to have fibrous tissues you're working with, you're going to work maybe sometimes with recessed tissue. So again, your isolation method is totally determined upon what that patient presents with and how they're presenting it, and how you choose to go and isolate that area. Got a few more good questions coming in here. One question is, what does chlorhexidine help with? I like to use the chlorhexidine again to scrub my final preparation before I go ahead and isolate for my preparation, or rather for my impression. Chlorhexidine removes contaminants to any kind of tooth debris, etc. I have another question about what impression material do I recommend. You'll see I've got impressions here from different companies. I got a variety of impression materials I like to use. I've got combinations. You'll see some monophase, some dual phase. I like to work with impression materials that I know I can syringe easily. You're going to see some color combinations that I like to see for contrast as well. So those are all kind of critical in how I choose that material. I think you need to look at what your colleagues are using too, and if you go to any kind of technical, any kind of dental shows, any kind of meetings, play around with some of these materials, because some of them express easier. Do you have another consideration is, do you have another assistant who can come in and help syringe while you're doing this? Because this is a time procedure, and a lot of what we're doing fails because we don't time it right. So a lot of things that go in play there. Are you using a fast set or using a slow set? We'll come up on some of these questions here in just a little bit and really tackle that a little bit better here. A couple other questions here. What level do you leave your margins? We're going to talk about that in just a little bit. That's very determinant on the tissue type and how much sulcus you have that you can actually prep to. Question here is very good. What do you do with your crown preps down to the CEJ due to cracked tooth or decay? In that case, I absolutely would look at doing, probably having a periodontist involved with that and seeing if I need to do any kind of crown lengthening to expose that and to get a very good finish line on that. Those are very precarious situations. Again, everything is very individual, and how do you go about it is going to predict the long term and the longevity for that tooth and that health for that patient. How do I finish my margins? Most of my finished margins on a gingival crest, if I'm going to choose to do that, are going to be a chamfer type style finish line. So I'll use a chamfer finish on those. And again, we've got great products. We've got the zirconias that are out there now that we can answer to that. So those are great aesthetics and a great solid, strong product as well. All right, I'm going to go on a little bit here and talk about some of the impression material we were kind of touching base on earlier. And these are some rules of thumb that I use when I'm deciding what kind of material I'm going to use. Number one, if I have 1 to 2 preps, I'm going to go ahead and choose a fast set material. If I have more than 2 preps, automatically I'm going to go ahead and choose a slower set. So the difference is just a couple minutes. But a couple minutes is very marginal compared to having to maybe remake it or try to push the extent or the length of time and the working performance of that material. So don't put yourself in that situation. Always err with caution and always prepare yourself, because that way then you don't have to back up again or maybe have to redo it and go into that remake phase. So again, impression timing is very critical. 1 to 2 preps, fast set, go the slower set if you have more than 2. And these are, again, considered within the same quadrant as well. And then you need to look at what kind of material you're going to select, monophase or dual phase. And that's going to essentially be the same type of material within the syringe or the tray, or you're going to have opposing materials with the delivery in the tray versus what you're going to syringe around the teeth. Preference here next is viscosity. And not only is that a preference difference, but it's also a performance difference. So if you have tissue that you know that you need to syringe around and you need to make a combination, maybe a fibrous tissue, you're probably going to select a high and a low viscosity. If you're going to have materials that you need to go in greater than 2 preps, you want to probably have a medium and a low viscosity, so that when you go to seat the tray, you have the proper amount of vertical drive into that arch to create that good impression. And finally, one of the last things we need to absolutely consider is the delivery method. Are you doing a dispensing or using a dispensing gun? Are you using an auto mix machine? And then does that, again, capture another assistant and require them to come into to the operatory to assist you in doing this? So again, this is just kind of a decision-making tree, going down step by step. How do I make right decisions to deliver a right product for my patient? Here's just a monophase example here. Monophases are great. I really like these for impressions, for implants. I think they're excellent for that. They're super good consistency. They have a little bit shorter working time. They're perfect for that, especially if you're going to do any kind of open tray method with the implants. You can see it especially in the top picture. But they're super good for implants. They are my number one for that reason. They also help reduce inventory, which is kind of nice, but I do not use these technically at all when I'm doing traditional crown preps, inlays, or onlays. I'm going to go ahead and go to a dual phase. And that's what dual phase impression material looks like. You're going to have the color contrast. Here you can see the yellow and the blue on the top. On the bottom here, you can see this is I do believe a FlexiTime here, and this is a Kerr product, a Take One. So you're going to look at different materials. These marry 2 different viscosities. The nice thing about this is, again, the color contrast, and I like the control that these bring, because I can syringe around here, again, capture the occlusal surfaces that are adjacent and opposing. Look at the nice flow of the vestibule. You can see here we've got good capture in this whole area. This tray placement is very ideal. Very, very ideal, and critical to know that you've got that. They allow a good working time as well. The next thing I want to go talk about a little bit is tray selection. And I think often we try to push the limits and the performance abilities of what our trays do, and then we end up dropping back and saying, you know, I should have done something different or better. But trays are critical in fitting and frameworking that impression so you get a good capture for your lab. My rules of thumb are, if I'm going to have 1 or 2 crowns, I'm going to go ahead and I'm going to work and grab a triple tray or a quadrant tray. And that's making sure that I have good occlusal stops as well. You'll talk to labs, and often they have no occlusal stops. They might have a crown prep on number 2 and number 3. They have no good occlusal stops up to just maybe the canine or something. You can't expect them to know. They're guessing at that point in time. There, I would jump over to a full arch. So make sure that you know you've got good stops. So barring that you have 1 to 2 crowns in the same quadrant, good occlusal stops, I'm going to go ahead and select a triple tray or quadrant tray. If I'm going to do a bridge, automatically, anywhere in the mouth, I'm going to go and select a full arch tray. If I'm going to do a molar or a second molar, again, triple tray or quadrant tray. That's a pretty well go-to method. And we're going to show some triple tray techniques here in just a bit too as well. A bridge, again, full arch, anything that's involving a molar or second molar. If I'm doing an implant for just a single molar or second premolar, I will select a quadrant tray. I have no problem with that articulation. That works usually very well. Here's a great tip here. With aesthetics and premolars, absolutely on number 5 and number 12, the first premolars, make sure that you have an anterior triple tray to capture that symmetry. You've got to have something that shows the opposite or opposing symmetrical tooth so that your ceramist can have a good idea what that needs to look like when they create that restoration. Anteriors, I love to use full arches because they're going to capture those occlusal stops again. We've got to have that. Very, very important. I've got a lot of good questions coming in here, and we'll try to touch base with some of these as we're going to go forward here. Again, we've got things talking about margins. I'm going to touch on margins in here a little bit here, so if you can be just a little bit patient, I'll talk a little bit more about that in just a bit. Timing, really critical. Absolutely use a digital timer. Don't rely on a traditional clock. It's not going to work. If you're working with a fast set material, you essentially have about 35 to 40 seconds from the syringing start. What I like to do is I like to bring in another assistant, and I have that assistant, once I begin syringing around the prep or preps within that quadrant, I will have that other assistant go ahead and start to syringe the material into the tray or the triple tray or the quadrant tray, okay? So I'm actually employing one assistant who's dedicated with me, making sure the patient and the preparation is isolated, everything's comfortable and ready to go. The second assistant is actually syringing. I think if you use and tandem that and work with that kind of system, it works excellent. I like to do that. We really can, you can really reduce timing issues and remakes if you employ both assistants when you're going ahead and dedicating that time and that focus. It takes a lot of stress off of you. I like to go ahead and I like to rinse and air my own preps, and then I syringe. And my chair side is absolutely right on it, totally focused. The second assistant's there syringing the tray. If you're using regular set, you have a little more time. You've got 1:10 seconds from that start. And again, these materials, fast set will usually, now fast sets are out there, I think one of the quickest ones right now, 2 minutes 15 seconds, 2 minutes 30. That's pretty quick. Regular sets, you're looking at around 4.5 minutes to 5 minutes technically. Again, if you have more preps you're working with, full arches, difficult isolation, you're going to go to a regular set material. You can't stretch that time. You can't work that fast to make that happen and make that happen well. So drop back to a better choice in material and you'll do better. Triple trays. I absolutely love triple trays for certain, again, procedures like I've mentioned in the past here. They work well, but they need to be selected. They need to be fit properly. Make sure your triple tray clears the retromolar pad area. Make sure you don't have occlusal interferences. Sometimes there's cross bites. Sometimes there's teeth that are not in proper occlusion or they're malaligned. They can create issues. Make sure that triple tray, once that patient bites into it, you know exactly. They can repeat that again when you come to take that impression and finalize that. Also, I do believe in painting that tray with adhesive. I think you get a much better capture, and I've been doing that for quite some time now. It has really improved our impressions. It's unbelievably good. So go ahead, take the time. You need to paint that adhesive on there with your polyvinyl. Absolutely make sure that you're going to get that dry. It takes about 15 minutes to dry that tray adhesive, but it will pay off in the long run. Some of the pitfalls of triple trays, and you can see this example is really kind of nightmarish, but this had very limited occlusal stops, and it was more of a flimsy tray. I'm not real pro on this because it looks to me like more of a mouth guard impression, but can you imagine, this is the opposing arch. What did the preps look like on the other side. I mean, this is kind of scary. So again, you got to have repeatable seating into that tray. Know that you can make sure that patient's going to close and have a little more predictability when they're going to close. So I'm going to give you a nice little example here of what one of the tricks we do. A lot of times when you're selecting a triple tray, you don't clear the retromolar pad, so you need to make sure it's long enough. Oftentimes the trays are too short, and then you're short on the material, you're short on the bite. You have an interference when they go to close, and so they kick the tray off to the side, and you don't have a good capture, and you've already then messed up your occlusion because you're relying on that triple tray to go ahead and record the occlusion as well as the impression. So you can see in this example here, I had a patient come in and they went ahead and cracked off the distal lingual cusp. They got a prominent fracture line here, gold crown back here. Crown prep is going to be our choice. This is going to be an EMAX crown. But you can see what I've done here. Because of the length of this arch, got that wisdom tooth back there, I've got to continue to make sure that material goes all the way past that to that retromolar pad, and my triple tray has to go back in here. There's some nice T-lock trays out by Premier right now that are excellent for this. I can go ahead and fit this in there, clear that retromolar pad and the wisdom tooth, and I do well. You can also notice one of the little tricks we use, we go ahead and take a Sharpie marker and we mark where we know we need to close to. In this case, we're closing right where the canine, and we're making a mark right down, so I know when I go to seat this, I'm getting near that canine, I know that's exactly where I need to be positioned at. And then I can go ahead and take that impression and make that happen. So critical, again, use some little tricks like that. Get that Sharpie marker out, mark that delineation, so that's going to help you sight that in there, because more often than not, you can't your occlusion when they're closing on these things, or they go to open again or try to close again. It's kind of like relying on the impression. You're going to have voids, bubbles, you name it all. So don't go there. Make it even and make it simpler and easier for yourself. Stock versus custom trays, another important thing. If you need to, here's a really good example. Here's just a sampling of some of the trays that I have within my practice and impression gear, but you can see here we've kind of customized this tray so that when this patient goes to have this impression taken, this will clear their tori. So we've used actually a little heat. We've warmed this up, tempered it with some warm water, and made sure that fits in there properly. So we had to do that because we could not do a triple tray impression with no posing on top. So that was interesting how we did this, but again, you can see the tray adhesion here. The adhesive is painted on there. Allow that to sit for 15 minutes. Stock trays are going to use a little more material. They're going to use probably about 3 times as much. And they do have a good vertical drive. Some are a little bit better than others. Go out there again. Try and see what works best. You can see here how the nice capture is of these margins here. We got a good vestigial capture. Custom trays again. Some are getting better, and they're improving all the time. Stock trays, I should say stock trays are improving. Custom trays are still the gold standard, and if you still need to do those, they're going to have certainly improved accuracy and a lot less material you're going to be using and more uniform thickness. So if you have a difficult case, just go ahead. Hey, make a stock tray. Have your lab make it. That's worth its money in gold because it's going to give you a better impression down the road. Let's talk about some margin placement. This is really critical as well. Always the questions come up about where you placing your margins. First and foremost, look at the area where this impression is going to be taken and the preparation is going to be made. Get out your periodontal probe. Measure around the tooth. If at all possible, we like to have impressions now in the anterior area, just tuck slightly underneath the gingival collar and do that safely, and you can make that happen so it's aesthetic and it's cleansable. Equigingival margins are great in I'd say the second premolar and molar region distally. Again, get the periodontal probe out and see and measure. Again, this is a time too where you're assessing what kind of tissue type this patient is presenting with. Subgingival margins are the most difficult to capture. Obviously, they're the most aesthetic, but there's definitely risk of destroying some of those fibers when you're trying to reflect or deflect that tissue and get into that sulcus. So you got to be cautious with margin placement. Here's some rules that I like to consider every time. Get your periodontal probe out. If your sulcus is less than 1.5, you can easily put your margin placement about 0.5 millimeters below the crest. We're not going to violate any of these very important tissue and epithelial connection rules. So we're going to have good junctional and connective tissue, and we're respecting all of those attachments. Very, very critical. Rule number 2, sulcus. If it's greater than 1.5, you want to place that margin at 1/2 the distance of the sulcus below the crest. Very important. If you have a sulcus that's greater than 2 millimeters, you need to look at probably doing a gingivectomy. And that can be done either a periodontist or go ahead and get your laser out, but do it carefully and do it cautiously. But these are very good rules of thumb. You're very safe within this realm. But get the perioprobe out. Get your articulating paper out. These are little tricks and tips that you can make very good product with and less headache down the road. I'm going to focus last here on tissue management because this is so very critical, and we can save ourselves so much hassle and headache and stress if we just kind of stop a little bit and look at what we need to do. Bottom line, you need to prep every tooth with respect. And when I say that, you need to make sure that you're not notching the tissue, you're not damaging the tissue. And I share this example only because this is a patient that in no way, shape, or form I think you're going to be able to create adequate hemostasis to make an impression this day. In this case, on this exact patient, my bottom line is temporize that patient, get the gingival tissues to heal better, send them home with some chlorhexidine, and have them come back. I'd give them about a week to 10 days, have them come back. We've got healthier tissue, healthier temporaries, the teeth are looking better, we can go forward now. But if you think you can do an adequate impression, multiple teeth with a oozing oral fluid crevicular nightmare like you see here, it's not going to happen. Another thing you need to consider too is that future, that periodontal stability. You don't want to disrupt that. So, even if, some people can argue, oh, I can go in there with a laser and make that. No, you're not going to be able to do that. This is a tough case. So back it up, do it proper. Get some temporaries on there. Don't push the limits again. Make sure you know your considerations and your limitations. Really critical. Tissue biotypes. Obviously extremely important in the anterior area. In the lower right, you can see here I've got an example of a scalloped or a high smile line. You've got to be very cautious when you're putting any preps in there. The question came up earlier, what am I going to do with this? Well, this is a tough case. And you're going to need to get the perioprobe out, measure, make sure what you have is going to be so slick and smooth, and that sulcus is going to be able to be managed properly, not to agitate or to irritate it. But these are challenging cases. Know what you got on the outset, what you need to do. Again, normal tissue is always easy. Another challenging case is a thicker fibrous tissue. And often we have to absolutely make sure we're using retraction cord. We can't rely on retraction paste to make that happen. And I'll talk about some tricks on that here in just a little bit as well. Some of the retraction methods that we're using nowadays are absolutely great. We've got good retraction cord out there now. I like some of these compression caps. They work very well. I do have a diode laser I use in my practice, but I don't do it very often with impressions, and I certainly don't do electrosurgery. So I like to stay in the retraction cord compression cap mode, as well as I use some chemicals now, and I like to use a lot of the retraction paste. I think they work very, very well, and I'd like to share a couple examples. Most of these now have great astringent hemostatic abilities within them. Most of the pastes are made out of aluminum chloride, and those within a combination of retraction paste and a compression cord, or compression cap rather, work very, very well. Cord, it's a necessary thing. Absolutely make sure that you're using a cord that you feel comfortable with. Sometimes even just changing maybe the way that you're cutting it, or perhaps maybe the way you're placing it, or the tool that you're using is critical. But make sure you're comfortable with the kind of cord. There's a lot of varieties out there right now. Some are braided, some are knitted. You have a whole different level of choices that you can use: braided, knitted, twisted, whatever works well in your hands. But bottom line, I like to use some braided cords. I like to use cords that I know will stay in place, and they are functional and they're solid, and they will help dry that sulcus area. They need to be placed for 4 minutes. And make sure absolutely certain that you have no latex contact whatsoever with that cord. That will interfere with a polyvinyl impression. It will contaminate it. I like some of the little caps and delivery systems now. You can customize these. You can see in this example here, you've got a little cutter on this this cap here, and that's a really nice little delivery system to use. Again, these retraction cords can be customized in combination with some of the retraction paste. Most of us know about when we're placing cords now, you need to have a single cord technique like I showed earlier, where I was actually placing that cord, the 00 cord, once I had my interproximals exposed, and then I go ahead, you can follow up with a larger cord, or you can, again, marry that or combination that with some type of retraction paste. And I find myself doing that more and more today because I know I can be kind to the tissue and do a very, very good impression with that. Implant impressions. I think most of us are doing more impressions than ever, and I'm showing this example because in some cases, if you do have a system whereby you're taking a custom abutment impression for that crown, you've got to have good retraction. You've got to be careful that you're not disturbing all of these neat little peri-implant junctional epithelial fibers. Very critical. So here I've got a very nice knitted cord placed in here. I'm using a non-serrated placer. Packer, okay, does not have any kind of teeth on it. I don't want to scratch anything on that implant, but it's very kind. It's kind of even like a spoon kind of quality. I do more of a lateral packing to place that in around the sulcus. Some of my favorite things that I like to use right now are retraction pastes, and there's some great ones out right now on the market. Expisil was the first one to kind of hit the market, and I think it's pretty tried and true, but a couple other ones that are out there now I think are absolutely gangbusters. They work well, and they deliver what we need to use in our practices daily. I like Traxident. I think it's a great, great product. It has a broad spectrum. You can use it with any kind of impression material. Expisil does have a limitation. You can't use it with polyethers. So you got to be careful with that. If you're using any polyether impression material, do not use Expisil with it. It will contaminate it. So I like to use something I can use across the board. Traxident answers to that. I like that it has no tissue discoloration. It's easy. It's a syringent. It has an unbelievably great absorbing ability of crevicular fluid. So it's a great win-win. And when I'm using that in combination with a retraction cap, I can very well know that my impression is going to have good cellular absorption. It's going to have great dryness. These are great things for patients to bite down on. You can see here, it's nice and comfortable for that patient to close on that while that material is working. You like to let that retraction paste sit in there for probably about a good 2 minutes, and they do very well. I like these, again, retraction caps here. You can see there's different sizes. In this instance here, we're using a molar. This kind of cups, this will be on the facial surface. It'll be in our proximal or buccal here, and this is the lingual surface. But you go ahead and place it in, have the patient close, so now they get nice gentle pressure, they got ability to close on that, and more importantly, you're really absorbing any kind of additional fluids that are out there in that cellular little trap that you need to get cleared and get clean. A couple examples I want to share with you here of cases that I'm using different combinations, and again, everything is totally individual. This first case, I'm using a retraction cord. It has an ecogingival margin, and I'm really going to wrap this cord maybe about halfway around the tooth. I don't need to go circumferentially around this preparation because I've got good marginal exposure. You can see here I'm placing this. I'm just kind of walking this cord in. I like to use a Fisher Ultra Pack, Fisher Packer cord. I also use a Garrison. There's I believe it's an NT 10 that I use in there. Those are great little cords, or Packer cords to use as well to or cord packers rather, to place those. If you walk this around, you can see here how I'm going to go ahead and again, circumferentially. I don't need to go completely around here. I just need to go where that sulcus area is covering that finish line. So now when I take that cord out, I can go ahead and get a good capture. One of the tricks I like to use when I'm going to go ahead and remove my cord when I'm ready to take that impression, this cord's left in for 4 minutes. This is a knit pack cord, by the way, Premier. It's a nice, nice cord to work with. I like to go ahead and I wet that cord, and then I will pull it out. Oftentimes, if you pull out a cord that's already kind of dried and absorbed, it doesn't want to remove as easily, and it has a tendency to kind of stir up things again. So go ahead, when you're ready to take the cord out, have you or your assistant rinse that cord, wet it, and it'll remove a lot easier, and it's a lot simpler. You'll get a better, cleaner impression. Here's another case here. You can see now I'm using combination where I've gone ahead and I've used Traxident. I've got that paste in place. I love that paste. It rinses so easily. You don't need a brush to scrub it. When you're placing this material, you need to make sure that when you dry the tooth and rinse and dry the tooth, you want to take the paste and you want to go slowly into the sulcus. You don't want to literally, you want to line it properly and parallel against the adjacent teeth, but you want to make sure that you don't go and jam down the tip into that sulcus. You don't do any damage, but you just want to go level along that gum line and let that go down into the sulcus. It has a nice placement to it. It's easy to place. You can bend the tip. It's easy to function, easy to place in hard to reach areas, and it just fits in very well. It's kind to the tissue too. It's not super acidic, and you certainly don't have any discoloration considerations, so that's all very important. Again, you can see I'm using a retraction cap then. You can see how the patient's biting on this, and a couple of things I really want to emphasize here, look at the nice flowability. Again, I'm capturing nice occlusal areas. This is a well-fit T-lock triple tray. We've got good flash around the margins here for the lab to capture. And more importantly, when I flip over, evaluate your opposing impression sides as well, those arches. Look here, look at the nice centered capture I've got on this tray as well. Very critical and very important to have that too. Evaluate, look what you have when you're doing these impressions. Make sure that you see both sides of that impression again before you send that off to the lab. Too often we box it up and send it out, and we really haven't paid attention to really the important things. And you got to make sure you got all those captures, both posing and what you're preparing, so they're ready to go. You want to just minimize your stress with that. Here's another case. I like this combination case because, quite frankly, we've got a prep that needs to have a little attention. We've got some area here now that's oozing and hemorrhaging just a little bit, so I need to have a little hemostasis. I've gone ahead and I've placed in here a zero cord, and on top of that cord, I'm going to take my retraction paste, and again, this is Traxident. Easy to bend that tip, easy to place, kind to the patient. And in combination, I'm going to go ahead and take my retraction cap, have them place this into position, and then have the patient bite into it. And you can see this last picture I'm exposing here is the picture of when we remove the impression. You can see how good that tissue looks and how healthy that looks. It's kind. It's going to be easy to make a very, very good temporary on that then. Now, to follow up with that picture, what I want to definitely show you here is how this impression looked. And since that was a premolar, one of my rules of thumb, again, is to have contralateral capture. So if you have a impression that you're taking, capturing this preparation over here on this premolar, I want to make sure that I have the symmetrical premolar capture, so now my lab knows exactly what that tooth needs to look like. Too often we can have something come back and they don't look like they mix and match, and it's like, avoid that. Don't do a quadrant tray, do an anterior quadrant tray that captures this. And you can see here, here's our T-lock tray here. We've got this completely covered with an adhesive, ready to go for a nice polyvinyl impression. And you can see how nice and captured that was, and it worked out very well. Couple last steps I want to focus on, and these again are very critical. Make sure you use a rigid bite registration material. It needs to be rigid, and the patient needs to bite. Oftentimes we'll go ahead and if we have any question on impression with especially a triple tray, we might even just take an individual bite registration to make sure our occlusion is recorded. So don't be afraid to do that. Don't do wax, but definitely do a good rigid bite registration. And I think the final thing you need to really consider is to have an excellent temporary, because temporaries are so critical in maintaining that mesial distal spacing. You want to reduce your adjustments. I like nice different materials that are out there now that have great cements to them. They have antimicrobial. This example I have here, you can see our occlusion we've marked in this bottom example, and we're using a NexTemp temporary cement, which is excellent. It's got chlorhexidine in it. It's got good fluoride release, reduces sensitivity, and our patients come back with very good temporaries. We always ask them, how'd your temporary do? You need to ask your patients these questions because it's really, really important for them to give you feedback and to say, hey, yeah, my tooth's good. This is great. It's better than what my tooth felt when before we started working on it. So make sure you're getting feedback from your patients on how they're performing with their temporaries. Good questions and good feedback help you to make yourself a better dentist, and get your assistants to rise up to that performance too, because my assistants, quite frankly, make the majority of my impressions, or rather not impressions, but temporaries. All right, and the last things I want to talk about here is saying thank you for joining the program today. There's a short questionnaire that you can do to get some CE credit. It's pretty simple to go through, but I hope and I wish the best of you and good luck with your improved impressioning. I know that maybe you have questions. I'm going to answer a couple of these questions here if I can real quickly, and then I would like to offer you any questions you want to further contact me. My email address is trost@htc.net. And I'd be happy to answer any questions. But I encourage you to communicate with your lab and look at your preparations and just look at the very bare basics and solid principles that you can improve upon, because I think you'll do a much better job. You'll certainly reduce your stress. And more importantly, you're going to provide a really excellent product for your patient. And that's a very important thing we want to do for our patients.